World Epilepsy Day celebrations in our Thrissur IMA branch. Thank you.
Thank you, Dr. Joy, for your words. Now, presidential address. Respected Secretary Dr. Pawan Madhusudanan, Dr. IMA Joy, President, Thrissur Neurological Society, Dr. P.C. Gilvas, Professor and HOD, Neurology Department. Today's introduction is will give the introductory speech, and who has arranged all the faculties of today's program. Dr. Jane Chimman, Joint Secretaries, IMA Kerala State, and other leaders from the state, Parid Saab from Malappuram, and many others, and the faculties, Dr. Fiju Chako, Dr. Narayan Unni, and all the other dignitaries on the Zoom. I welcome you all to this World Epilepsy Day observance. I miss Dr. Leelama Abraham, CGP Chairman, IMA Thrissur, and Dr. Sharmila, Convener, IMA CGP Thrissur. Also welcoming you all. I forgot to mention your name, sorry. So we are observing World Epilepsy Day today. International Epilepsy Day is a special event which promotes awareness among the public, the importance of epilepsy, and the precautions to be taken. And about which more elaborately it will be highlighted by the our faculties and Dr. P.C. Gilvas, who will give an introductory speech on that. I am not prolonging my topic, my speech. Now I invite Dr. Leelama Abraham, Chairperson, IMA CGP Thrissur, for her felicitation speech. Over to you, Dr. Leelama Abraham. Madam, unmute and talk. Unmute you. കേട്ടൂടാ അൺമ്യൂട്ട് ചെയ്യൂ മ്യൂട്ടഡ് ആണ് കേട്ടൂടാ ലെഫ്റ്റ് സൈഡിൽ മൗസ് കൊണ്ടായിട്ട്
Hello? Can you hear me?
കേക്കാം.
Can you hear?
Yes, ma'am.
The speech is not audible.
Audible, കേൾക്കാം. പറഞ്ഞോളൂ.
ഇപ്പൊ കേൾക്കാം മാഡം, പറഞ്ഞോളൂ.
Start.
Respected President of IMA, Dr. Joy Manila, distinguished dignitaries in the webinar, respected President and Secretary of Neurological Society, Thrissur, and my dear colleagues. It is with heartfelt enthusiasm, vigor, and dedication all of us are attending this webinar, even in the polluted atmosphere of COVID-19. So first of all, let me express my sincere respect and recognition for the untired effort, sincerity, and hard work taken by our IMA President Dr. Joy and Secretary Dr. Pawan for the great progress and success of IMA Thrissur. Thus, this year IMA Thrissur branch became the best branch in the whole of Kerala state. In addition, Dr. Joy and Dr. Pawan got the best President and Secretary awards also. Today, in this Epilepsy Day, we are blessed by the presence of Dr. P.C. Gilvas, Dr. Fiju Chako, Dr. Narayan Unni, Dr. Joy M.A. as our speakers. They are well-known neurologists, not only in Thrissur, but also all over Kerala and India. I am sure that they will enlighten our knowledge with their vast knowledge and academic bonsai. Even though IMA is celebrating so many days like Leprosy Day, World Leprosy Day, TB Day, Alzheimer's Day, etc., the Epilepsy Day is the most important for all the doctors, especially the general practitioners and other medical specialties like pediatrics, ENT, and even gynecologists. As doctors, most of us have met with some epileptic cases, acute or chronic, in our practice. So, this Epilepsy Day celebration is very precious and informative for all of us. So, I congratulate and appreciate the President and Secretary of Neurological Society of Thrissur. They, they are spending their precious time in the midst of their busy practice with us for giving us some knowledge regarding this epilepsy. So I express my heartfelt gratitude and I also wish all the participants a great success for this webinar. Thank you.
Thank you, Dr. Leela Abraham, for your kind words. Now I will invite Dr. Sharmila for the introduction of the faculties and the faculties. Over to you, Dr.
Thank you, sir. Sir, am I audible?
Audible.
Okay. Actually, today here on this World Epilepsy Day, we are honored to have with us the pillars of Department of Neurology Thrissur as our speakers. The first talk today is by Dr. P.C. Gilvers. Gilvers, sir, will give us an introduction to the World Epilepsy Day. Sir is a professor and HOD of the Department of Neurology, JMMC. Sir joined Jubilee as a physician in 1984, left for DM in 1986, rejoined Jubilee in 2000, and he played a key role in starting the medical college at Jubilee in 2003 and the PG Department of Neurology in 2013. The next topic is Basics and Practical Approach to Epilepsy. The speaker is Dr. Fiju Chako, Professor, Department of Neurology, JMMC. Dr. Fiju did his MBBS from Calicut Medical College. Dr. Fiju is a gold medalist in MD Medicine and DNB in 2000. Did his DM Neurology at PG IMA Chandigarh. He has around 10 publications to his name. And the next speaker is Dr. Narayanan Unni. Dr. Unni will be speaking on the topic of women with epilepsy. Dr. Unni is a consultant neurologist at Daya Hospital. He did his MBBS from Government Medical College, Thrissur, MD General Medicine from Rajendra Institute of Medical Sciences, Ranchi, and DM Neurology from Bombay Hospital, Mumbai. And now over to you, Gilvers, sir, for the first topic. Thank you.
Unmute, please unmute.
Luminaries of the Thrissur IMA who have brought laurels to this great body by winning the best IMA in Kerala. We are extremely proud of it. It's a great honor to be asked to say a few words at this National Epilepsy Day on November 17th.
Gilvers sir ഒന്ന് അൺമ്യൂട്ട് ചെയ്യണേ. ഞാൻ എല്ലാവരും ഒന്ന് മ്യൂട്ട് ചെയ്തിപ്പോ. Gilvers sir, please unmute.
Today is not the World Epilepsy Day. Today is actually the National Epilepsy Day, special to India. Now, why do we have a special day for a disease? The very key is to remember the disease. That is the idea. Now, why do we have a Father's Day? Why do we have a Mother's Day? On this special day, we remember these people in a very special way. So also with epilepsy. It also underscores the importance that epilepsy plays a very important role in our day-to-day lives, as doctors, as human beings, as patients. It's the day when we think about advocacy, when we think of doing something for the epileptic patients. It's a day when the epilepsy patients get involved and share their ideas, their experiences with epilepsy, so that the newly diagnosed ones with epilepsy become reassured that they are on to something which can be handled. Now, epilepsy is a very strange disease. We all know what epilepsy is until we begin to treat it. The definition of epilepsy has not changed over the years. An abnormal, excessive, hypersynchronous discharge of neurons. This is what Gibbs said almost a century ago. And that is held true even today. But when we are confronted with a case of epilepsy, now that's a different matter. Because epilepsy can be so diverse in its presentations, so protean. There can be so many epilepsy mimics. Every fall is not epilepsy. So it is so important that especially the general practitioner, the average medical doctor who sees these patients, be aware of what he is treating. That he is not treating something which is not epilepsy. This is most important. Not to treat what is not epilepsy. Because it's a matter of A, condemning him to a life of almost 3 to 5 years of drug therapy, of the side effects of the drugs, more importantly, the stigma of having been an epileptic. So therefore, it's important that we know the very basics of epilepsy. It can be just a staring episode, which can be so easily missed. Just a pause and a stare. Now, this will be picked up by close family members, but almost never seen by the doctor. Therefore, a trick which we normally employ these days is to tell the parents or relations, bring me a video clip of the event. Now, this is more useful than any 24-hour EEG recording, because here you actually see the event. And once you have seen the event, you know, is it a fit? Is it a faint? Is it a pseudoseizure? Right? So this is the importance of being familiar with what is epilepsy. The next thing to be familiar is the drugs in epilepsy. And finally, the thing to be important is what happens to a woman during her reproductive years with epilepsy. Now, these topics are going to be dealt with in a great depth and detail by the next speakers, Dr. Fiju and Dr. Narayan. I welcome Dr. Fiju on the topic of the basics, epilepsy and the basics and beyond. Over to Dr. Fiju.
Thank you. Thank you. Am I audible?
Right,
Am I audible?
Audible.
Yes.
now it is clear.
The next 15-20 minutes, we'll talk about seizures and epilepsy. Greetings from Jubilee. At the outset, let me thank the organizers and congratulate Thrissur IMA, the team, for having almost 2 meetings every week. It's a Herculean task for others to follow. Let me congratulate on behalf of all of us here, our President, Dr. Joy, and Secretary, Dr. Pawan, enthusiastic and done so many, more than 100 programs, almost 2 a week. We'll come to the topic proper. Seizures. One fix, that doesn't make it an epilepsy. Like one swallow doesn't make a summer. It could be a symptom of a hypoglycemia, a low calcium. It can start at any age. The first seizure may be starting at age of 90. It's very common. 2%, that should be 3 crores of Indians. It's very common. We had several important personalities. Napoleon, Newton, John T. Roth, so many people with epilepsy. And we can lead a near normal life. You all know about the stages of seizures. That's the classical GTCS. Sometimes there can be a warning, an aura. It could be a smell, an epigastric aura, something like a rotten egg or petrol. Then there is an epileptic cry. Against a closed glottis, there's a forced expression. Oh, that's a shout. a shrill cry, that's the sound. The eyes and head may turn to one side, stiff. That's a tonic phase. And then there's a rhythmic jerk, and then followed by a post-ictal confusion, vomiting, bowel bladder incontinence, and all. All seizures need not be that. It depends where is the epileptic focus, the symptomatic zone. In a motor cortex, we have this motor jerks. We have the Jacksonian mark. It may start as a twitching over the thumb. It may involve the forearm, the arm. Then it may spread to the other side, and once it's bilateral, we lose the consciousness and fall. There could be a sensory seizure. Yes, there could be a sensory seizure. We don't have a jerk. What we have is a paresthesia. It comes for 5 minutes, it goes. That's also a seizure. It could be auditory, it could be anywhere. Just to mention about the spectrum, it could be a complex partial seizure, a few seconds or minutes of altered behavior, lip smacking, nose wiping. There may not be loss of consciousness. They are doing something automatic, banging on the desk, staring. This could be a complex partial seizure. The drug of choice in a complex partial seizure is a carbamazepine or oxcarbazepine. The girl on bottom is having a complex partial seizure, a stare, looking into nowhere, some jerks, that's it. A blank stare, that's enough. She's not responsive during this period. That's a complex partial seizure. Once you find someone having a complex partial seizure, don't try to restrain or force. Guide gently away from hazards. And if possible, as Sir mentioned, if we get a video recording, that's good that we can classify the seizure. Now, what about myoclonic seizure? It's just a sudden jerk. Objects fall or fly from the hand. Panna, a toothbrush, it's often in the morning. A cup of tea, there may be a jerk. At the onset of sleep, there may be a physiological myoclonus. In a classroom, if someone is sleeping, the pen falls down. That's a myoclonic jerk, which is normal at the onset of sleep. In juvenile, adolescent, there's a JME. If it's severe and worsening, a regression of already attained milestones, it could be a PME. Sodium valproate and clonazepam are better. Look at the girl. She's going to have a big jerk. That's it. That's a myoclonus. The history of this nettle jerk is important because some drugs, we just mentioned carbamazepine, that may aggravate the myoclonus. The history of this jerk is important in therapy also. Now coming to absence seizure. This is in kids, LP school kids, say 5 to 10 age. School-going kids, they just have 5-second episodes of daydreaming, absent-minded. Endo സ്വപ്നം കണ്ടിരിക്കുന്നു. Teacher will find that this girl or this boy is staring somewhere few seconds every hour. There may be 50 attacks. The EEG is diagnostic. Look at the EEG here. It's a generalized chain, left, right, front, back. All the EEG panels, all the leads have the same change. It is every second there are 3 spike and wave. 3 spike and wave. The ILA, International League Against Epilepsy, has this logo. The spike and wave. A and E are made in such a way. Sodium valproate and ethosuximide are useful. The EEG is diagnostic. If we hyperventilate, this occurs. The boy is hyperventilating. Now he is having this staring. The EEG is corresponding, EEG is showing this. It's for a few seconds only, 5 to 10 seconds. They don't fall down. They don't have a GTCS. They have a poor scholastic performance. One drug and it's over. Coming to small kids with fever. All fever with fits is not febrile seizure. It could be the onset of a meningitis. 6-year kid up to 6 month to 6 years. It's like പനി കൂടുമ്പോൾ വിറയ്ക്കുന്ന പോലെ, shivering പോലെ. It's not an epilepsy. They need not have a daily anti-epileptic drug for the next 3 years. If it's brief, if it goes off on its own, it doesn't require long-term therapy or even investigations. Just rule out meningitis. Even intermittent therapy is sufficient. If there is a family history, father, mother, elder sibling having a similar febrile seizure, they don't require treatment even. Now, what are the investigations? A seizure is a symptom. It could be a symptom of a tumor, of a low sugar, of a hypocalcemia. We need an imaging to see that there is nothing abnormal in the brain. In an elderly, it could be a tumor. In a older person, it could be the onset of stroke. We need to see if there is a congenital malformation or anything. An MRI, preferably, or even a CT scan would suffice. Now, what about EEG? EEG is painless, non-invasive. It's almost 100 years, 1924, when a, a rat EEG was taken by German Hans Berger. The EEG is non-invasive, painless, easy. We can classify from which side of the brain, what sort of, if it's a non-convulsive status epilepticus. Somebody after a series of seizures is not regained consciousness. The jerks have stopped, but the electrical abnormalities are not stopped. It could be an absence or a plex, a periodic lateralizing epileptiform discharge. Temporal lobe epilepsy, temporal lobe changes could be due to a herpes simplex, a viral encephalitis. Now, several kids may faint during the assembly while standing for prolonged period. It's not seizures. Hearing a bad news, skipping a breakfast, not hydrated adequately. Look at the other signs like sweating, nenjuvena, nenjidippu, vayarappu, pale or blue, cyanosis. All these are clues. If you have a cardiac rhythm abnormality, it's easily picked up by this home halter. This is a home halter, a sticker the size of the palm. It's stuck here, it's paired by Bluetooth to the mobile, and it records the ECG for 72 hours. It's like 3,000 rupees, and it's connected by Wi-Fi to net, and the report is available. Any first degree block, second degree, third degree, or atrial fibrillation, most difficult is the intermittent ones. When you see it's not there, it must have come and gone. The paroxysmal atrial tachycardias, they are difficult to pick. If you have a 72-hour recording, now 7-day recording is there, with which we can even take bath, can go for work. This person came with few episodes of fainting, a few jerks even. He was put on anti-epileptic, but there was something fishy, some palpitation, some sweating. We took the halter, and after the 3-day recording, there was long pauses. Here it's a long pause. It's a sick sinus syndrome. The pause was going for 9 seconds. He was immediately taken up for a pacemaker. This web cardio is a wonder investigation tool. It's only 3,000. One medical rep, Mr. Udayan, was doing working in Thrissur for 2 decades. He's doing this at 3,000 rupees. It's a good diagnostic tool. Now, as most important is the history. What exactly happened? A teenage girl, the mother comes, she had thalajute. Don't start beta histine or vertin or whatever. What happened? What exactly happened? Since there is a taboo and stigma for epilepsy, many people won't really tell what happened. We have to ask what exactly happened. Thalajute, yes. Don't interrupt. Most doctors, they say, 2 years back, London study, they say, every doctor, average doctor, interrupts the patient by 11 seconds. Where exactly is the pain? Point with one finger, and we interrupt. By 10, 11 seconds, we are impatient. Our father of modern medicine, William Osler, has said, listen to your patient. He is telling you the diagnosis. Just ask leading questions. No, just open questions would suffice. The father of modern neurology, he says symptoms are nothing but a cry from a suffering organs. John Martin Charcot, the French. So every patient tells a story, like the Rudyard Kipling. Who, where, what, exactly, why, when, how. That will reach the final diagnosis. So coming to the therapy, anti-epileptic drugs. I'm not going to bore you with the pharmacotherapy pharmacology classes about individual drugs. One drug is sufficient. A single drug is our aim. We have to, one dose may not be sufficient for a day. If the half-life is 12 hours, we have to give it twice. Half-life is 8 hours, we have to give it thrice. Increase to maximum till there is a seizure control. If not controlled, add the second drug. If it's controlled with the second drug, we may try tapering the first drug. Try to be on a single drug. In hypertension, we may give amlodipine and atenolol or metoprolol. The side effects tend to cancel out each other. One causes tachycardia, one causes bradycardia. We may give a calcium blocker and a diuretic. One causes edema, the other one reduces the edema. It's a continuous variable. Each drug will reduce 5 to 10 millimeters of mercury on its own. But seizures is like all or none. Either you control the seizure or you can't. So a drug has to be effective. It has to control the seizure. So it should fit the fix. In a complex partial seizure, oxcarbazepine is best. In a myoclonic seizure, valproate is best. In an absent seizure, ethosuximide or valproate is the best. So it should be depending on which type of the seizure. And it should suit the patient also. If somebody is going to be pregnant, valproate is not the best choice. The teratogenicity is a dangerous thing. So it should fit the patient also. And it should fit the pocket also. Since it's a long therapy, we have to take it for 3 years. It's like a preventive therapy. So they should be affordable. They should take it for 3 years. So one size doesn't fit all. A good physician treats the disease. A great physician treats the patient who has the disease. Again, William Osler quote. So it's not just the efficacy and tolerability, the risk and the benefit. The next thing is the cost, the affordability. Once in our part of the world, in a third world country, the affordability also matters. Why several people are not taking the drug? Several reasons are cited. Quarantine issues, we can't get the drug. Many people feel it's unnecessary. A week or so, 1 month, we can't take it for lifelong. The cost is one thing. They are afraid of the side effects. People are afraid that kidney and plain simple forgot. The doctor, the Latin word means to teach. We have to explain, convince them the need of this. Srinivasan meme. I'd like to tell that most people are listening to teachers and film actors regarding medical therapy. The pharmacy people or the medical lab people, they are advising against cholesterol normalize, now stop the statin. The BP normalize, now stop the hypertensive medication. I would say IMA medical advice should be sought from the medical people, not from teachers or cinemas, film stars also. Keep calm and take your medicine. Why? What about medication adherence? A chronic therapy, hypertension. Marinnu nirthiya, they have a rebound hypertension that can produce stroke, come to stroke, 1/3 of stroke. Even 37% of stroke is due to not treatment of hypertension. Those have already started, they stop the medicine, they have a rebound and they have a stroke. Seizure recurrence. Stratus epilepticus, commonest cause is missing the drug suddenly. The US, why talk about US? Because they have the data. More than 1 lakh deaths are due to non-adherence. Disability is 10 times dollars, like $300 billion, big economics involved because medication adherence is poor. This study came last week about statin, Samson study. We talk about placebo effect. It's a negative like placebo effect. People are, they know about statin. It causes muscle pain, aches here and there. So some people were given statin and some people were given placebo, a sugar pill. And those on the sugar pill also had the aches and pains of statin. When they were told that it's not due to the statin, you are not on statin, it vanished, and they could, half of them could be restarted on statin. It's a nocebo, a negative placebo effect, perceived symptom due to the act of taking a tablet. People feel that so I have to take so many food and they gain weight. many side effects are just like a placebo positive effect, nocebo is a negative effect. Coming to most literate state of Kerala and the cultural capital, Puram, Adirappalli, all this. This key is a story I have to tell. At a government medical college, Mulanthau, where Shaji was working, one person had a big seizure and he was going on seizing. Somebody gave this rusty metal key and he had the seizure and he aspirated it. He had to be taken to the gastro, endoscopy done and removed. This happened just 5-6 years back from the most literate state and cultural capital. It is an indicator that Sakshara Kerala, Prabuddha Kerala, all this are not related to they may be having a non-medical PG degree, MSc Science or MA English ആയിരിക്കാം. പക്ഷേ regarding medical knowledge they are laymen. And we have not educated them, convinced them fully. We have failed in convincing them. To doctor is to teach. We have failed in communicating to them the importance of medication and the basis of seizure, and this metal key is futile and useless. Just like starting a therapy, also stopping, unnecessarily starting a therapy is also dangerous. Gilva sir at the outset had started that. It's like a Kodadile judge sentence on 3 or 5 year sentence. All jerks are not seizure. All twitches in ICU are not seizure. Palarum ipo levitrastum, mere paas ma hai ennu parna mari, any jerk in the ICU, somebody starts on anti-epileptic, nobody dares to stop, nobody else has seen. If a house surgeon or somebody in the ICU has started levitrastum, he takes it for on and on for 3 years. All jerks are not seizures. ആവശ്യമില്ലാതെ തുടങ്ങരുത്, ആവശ്യമുള്ളതിന് കൊടുക്കുകയും വേണം. What's the first aid? Stay calm, loosen the clothing, let them stay on the side. ഛർദിൽ വന്ന് ലങ്സ് ബ്ലോക്ക് ചെയ്യരുത്. We have to shout to the bystanders. ഇപ്പോൾ റോട്ടിലൊക്കെ ആണെങ്കിൽ, ഇപ്പോൾ പള്ളിയിലോ വഴിയിലൊക്കെ ആരെങ്കിലും, I'm a doctor. We have to act confident. ഷൗട്ട്, നീങ്ങി നിൽക്കൂ. ഫെയിൻ്റ് ചെയ്യുന്ന സിങ്കോപ്പി ഉള്ളവരെല്ലാവരും കസേരയിൽ പിടിച്ചിരിക്കും. എന്നിട്ട് അവിടെ കിടക്കട്ടെ, കാല് പൊക്കി വെക്കുക വേണ്ട, തല്ലിക്ക് ബ്ലഡ് ഓടണം. വി ഹാവ് ടു റൈസ് അവർ വോയിസ്, അവർ ബോഡി ലാംഗ്വേജ്. വിരൽ വെച്ചാൽ വിരൽ കടിച്ചു മുറിയും, സ്പൂൺ വെച്ചാൽ പല്ല് പോവും. If it doesn't get controlled in a minute or two, better take to hospital, get the sugar check, get the IV injection if it's not controlled. Coming to status epilepticus, prior definition was 15 minutes. Now it's 5 minutes. If they are not regaining consciousness or the seizures are recurrent, check the sugar, sodium, give lorazepam is better than diazepam, 4 milligram IV, then fosphenytoin or phenytoin. Fosphenytoin is preferred because it can be given faster. 1000 phenytoin is equivalent to 1500 fosphenytoin. They are equivalent. Levetiracetam 30 mg per kg, valproate 25 mg per kg. Half dose of this fosphenytoin may be repeated if seizures are not controlled. Midazolam drip if it's not controlled. Phenobarbital, there's a chance that they need ventilatory support. Midazolam drip is useful in resistant refractory and super refractory cases. We may need anesthesia proper, like propofol and thiopentol. What is drug-resistant seizures? The definition is, if you have tried 2 drugs, 1 or 2 drugs, appropriate drugs, 2 drugs, adequate duration. If it's not controlled, it could be a medically refractory seizures or a drug-resistant seizure. There, surgery is an option. You have to work up for. If it's a focal seizure, an irritant focus is there, it has to be removed, a lesionectomy. Very often it's the anterior temporal lobe which is the problem. Our Sri Chitra Trivandrum has the best statistics, 300, 400 cases. 75% of them could be off drugs after the surgery. Multiple drugs, they were not controlled. After the surgery, they are off all drugs and no seizures. Sometimes it should not spread to the neighboring sites. The vertical downward action the signal is okay. The spread is prevented by a multiple subpile transection. A lesionectomy or a hemispherectomy are the other options. And funny to say, up to 10 or 20% of the cases referred for epilepsy surgery, 20% of them could be non-epileptic or psychogenic seizures. They have epilepsy and they have stress. They have both epilepsy and non-epileptic seizures. They faint. They are in after the quarantine and all. There are like one a day, more than 180 suicides of kids below 18, and 10 times unsuccessful attempts, and 100 times hospitalization requiring depression or psychiatric problems. So someone with epilepsy, they can't have schools, friends. They are locked inside a house, and lockdown has a tremendous effect on our psychological well-being of kids and adults and elderly, everyone. So up to 20% of those referred by several doctors have seen added on 2-3 drugs, they still have psychogenic seizures. So every seizure, just do not add on the drug, increase the dose. Every seizure, second event, third event, what exactly happened? Again, history is the key. If you have a mobile video, we have to see what is happening. Sometimes there are clues that someone is recording. They look at the camera. Seizure ഇങ്ങനെ അടിച്ചുകൊണ്ടിരിക്കുന്ന ആള് വീഡിയോ റെക്കോർഡ് ചെയ്യുമ്പോൾ അവിടേക്ക് that's a peek at the camera, look at the camera. They automatically adjust the hair or clothes. That's all clues regarding it not being a seizure. Now, when regarding stopping treatment, if the person is seizure free for last 2-3 years and the age is normal, we can stop. Don't stop abruptly. Stop like 25% in first month, then 50% second month, third month 75%, like 3 or 4 months, taper over several weeks or months. That's all, folks. Now we have to educate regarding it's a preventive care, not like an antibiotic for 5 days or anti-inflammatory for a week. It's like 2-3 years. It's like insurance, car insurance. It's a protection. You don't have a seizure. You are asymptomatic now. Still, you have to take this drug day in day out. മരുന്ന് മുടങ്ങരുതെന്ന് നമ്മൾ ഇൻസിസ്റ്റ് ചെയ്യുമ്പോൾ വി ക്യാൻ ഹാവ് ദിസ് സോർട്ട് ഓഫ് സൈഡ് ഇഫക്ട്സ്. സ്റ്റീവൻ ജോൺസൺ ഒക്കെ വരാം, അലർജി വന്നു അപ്പോഴും അവർ കഴിച്ചുകൊണ്ടിരിക്കും, ഡോക്ടറല്ലേ പറഞ്ഞ മരുന്ന് നിർത്തരുത്. So if you have allergy, itching, rash, redness, chicken pox ആണെന്ന് വിചാരിക്കുക, it may come after 2 weeks. You have to seek medical attention, report immediately, show this prescription. ഇതിന്റെ അലർജി മേ ബി 2 weeks or 1 month ആയും വരാം. You have to stop the drug. You have to use diligence. Do's ഉറക്കം മുടങ്ങരുത്, മരുന്ന് മുടങ്ങരുത്. Don't no swimming. Swimming is dangerous. Driving, alcohol, all these are risky. ILA, IMA, Kerala Neuro Association, everyone is with you. We have to support them. Several പ്രതിഭകൾക്ക് വരെ ഈ അപസ്മാരം ഉണ്ടായി അവരെ അതിജീവിച്ചവരുണ്ട്, മുഖ്യധാരയിലേക്ക് വന്നവരുണ്ട്. It's not like you have to be withdrawn in the side, but you can be in the mainstream of society. Thank you.
Thank you, Fiju. I think that was an excellent covering of the basics, what every practicing doctor needs to know. We now go on to, we'll take questions at the end. We'll now go on to the very interesting talk by Dr. Narayanunni on women with epilepsy, because they have 2 lives to think about. So let's go on to Dr. Narayanunni and women with epilepsy, WWE. Unni, are you there?
Yes, yes.
Share screen. Share screen.
Yeah, I'm sharing. Did that come? Am I audible?
You're audible, but no screen.
Audible,
Screen.
audible. Screen sharing enable ചെയ്യൂ. Share screen അടിക്കുക.
Bottom green arrow. Share screen. എന്നിട്ട്
Yes.
ഡെസ്ക്ടോപ്പോ അല്ലെങ്കിൽ പവർ പോയിന്റോ.
Yeah, you're on.
Okay, so first of all, let me thank the office bearers of IMA for having extended me this opportunity to talk on women with epilepsy on this National Epilepsy Day. So from the basics, we will go to a more specific topic, that is women with epilepsy. We know that the incidence of epilepsy in men and women is similar. The fundamental principles of management are the same. However, managing women with epilepsy requires attention to special considerations. It is estimated that 3 to 5 births per 1,000 will be to women with epilepsy. And possibility of a pregnancy should be considered in any woman of childbearing age with epilepsy. Why is this unique? Why is epilepsy pattern in women unique? Are there any unusual epilepsy patterns in women? Yes, answer is yes. There is this phenomenon called catamenial epilepsy, where you get more seizure proneness, more epileptic attacks during the menstrual period. Catamenial epilepsy refers to a demonstration of a doubled daily seizure frequency at a particular phase of the ovulatory cycle in at least 6 consecutive months. We know that the estrogens have a seizure promoting effect and progestogens have a seizure inhibiting effect. Accordingly, there are 3 patterns of catamenial epilepsy that are described. One is during the period day 10 to day 13, which corresponds to a periovulatory estrogen peak. The second corresponds to day 1 to day 3, where there is a perimenstrual fall in the progestogens. And another one is with regard to the disorders of the luteal cycle, where the second half of the cycle from day 10 to day 3 can be seizure prone. How do we treat the catamenial epilepsy? If the patient is already on AEDs, then a small dose of clobazam given perimenstrually should suffice, 5 to 10 mg. Other options are daily acetosalamide or intermittent progestogen supplements. If the lady is not on anti-epileptic drugs, then clobazam 5 to 30, a higher dose may be required in the perimenstrual period, or you have the option of intermittent progestogen supplements. Then another factor to look at in women with epilepsy is regarding the sexual dysfunction, which is frequently not discussed. The majority of women with epilepsy have normal sex lives. Sexual desire and arousal may be affected by epilepsy or its treatment. So inquiry regarding the same should be part of the standard evaluation. And if it is discovered, you have to have appropriate referrals for psychological and neuroendocrine evaluations. Many drugs, especially the enzyme-inducing drugs like phenytoin and phenobarbital, can increase the sexual and reproductive dysfunction in women with epilepsy. And lamotrigine is a drug that has been shown to have improved sexual functioning. And from sexual dysfunction coming to fertility, is fertility affected by epilepsy or its treatment? The answer is yes, a big yes. Definitely the birth rates are reduced, the fertility rates are reduced among women with epilepsy. Compared to the general population or compared to same-sex siblings, the birth rates of live offspring to WWE is very much decreased. So all women with epilepsy has to be counseled about their fertility and the possible effects of their AED treatment. Now, what are the factors which results in a reduced birth rate in this group? There are mainly 2. One is psychosocial and the other is biologic. Dr. Fiju did mention about the stigma that these patients have. And whenever it's a girl who has epilepsy, the most worried are their parents. They are worried about the marriage, and frequently they end up with no marriage or a delayed marriage. And we know that the more the age, more the chance of an infertility creeping in. And even if they get married at the right age, many of them choose not to have children because they have a notion that sometimes the disease can be transmitted to their progeny, and they choose not to have children. Then coming to the biologic factors, it has been shown in many studies that the women with epilepsy have higher number of anovulatory menstrual cycles, higher frequency of amenorrhea, and higher incidence of PCOS, the polycystic ovarian syndrome. PCOS, the gynecologists and endocrinologists will be more familiar with it than us neurologists. Just for completion's sake, we know that it has to have polycystic ovaries on imaging, or oligo or anovulation, and clinical or biochemical evidence of hyperandrogenism. Other features will be an elevated LH-FSH ratio, insulin resistance, and obesity. The prevalence of PCOS is definitely higher in women with epilepsy than in women without epilepsy, even in those not on AEDs. So it is not just about drugs, it is about the disease itself. Even epilepsy itself can cause PCOS. It is not drugs. But when it is drugs, the most common culprit is valproate. PCOS is more common in women taking valproate, especially those starting valproate before the age of 20. Now, coming to theory part of it, now one may think, how does epilepsy cause PCOS? A lot of ictal and inrectal discharges coming from the cortex and subcortical structures can result in hypothalamic dysregulation with increased gonadotropin releasing hormone release, with resultant increased LH-FSH ratio and an increased steroidogenesis, which results in more immature cystic follicles in the ovary, resulting in anovulation. Another hypothesis is due to the discharges, there can be altered LH pulsatility from the hypothalamus, which results in an increased steroidogenesis and reduced aromatase activity. Aromatase is an enzyme that converts androgens to estrogens. So when there is less aromatase activity, there can be a hyperandrogenemia with the resultant acne, hirsutism, alopecia, etc. So coming to another issue with women, it's contraception. So they have got married and they want to know about contraception. So how do you counsel a woman with epilepsy regarding contraception? So when it comes to OCPs, OCP may not be a very good choice in this subset of patients because most of the anti-epileptic drugs, especially the drugs given on the left, the phenytoin, phenobarbital, carbamazepine, these are the old generation drugs, and they can cause a lot of interactions, and they can render the contraceptives ineffective, resulting in unwanted pregnancies. Whereas the drugs on the right side, mainly levetiracetam, lacosamide, etc., which are the relatively newer generation drugs, they have no impact on OCPs. So OCPs may be an option in patients who are on the newer generation drugs, may not be a good option for those who are on the old generation drugs. So advice will be for non-hormonal methods like the barrier contraception or IUDs. But if at all the patient is on newer drugs, then combined OCPs may be an option. If they are on the older generation drugs, probably you will need to give higher dose of estrogen and additional barrier methods as well. Another option is using injections of medroxyprogesterone every 10 weeks. Now, what about the other way, the vice versa? Do the OCPs, what is the effect of OCPs on the anti-epileptic drugs? Yes, they can also interact. Estrogen causes an increased metabolism of AEDs, which are metabolized through glucuronidation, mainly lamotrigine, valproate, oxcarbazepine. Lamotrigine metabolism can be increased by more than 50% by OCPs. So the levels of lamotrigine may go down sharply with OCPs. But if lamotrigine is co-prescribed or when it is concomitantly used with valproate, valproate is an inhibitor. OCP is an inducer, so it may neutralize. But in the pill-free week, when you're using OCPs, there is a pill-free week. When the pill goes away, there can be a sharp rise in lamotrigine levels. So lamotrigine level monitoring is recommended in the context of an OCP use when it is concomitantly used with valproate. Now, after contraception, now the advice regarding pregnancy. How do you plan a pregnancy? So most of us neurologists do not have this luxury most of the time, because we meet them, they come with a report that I am already pregnant. Most of the time, that's what our experience is. But in an ideal scenario, we would like to get the patient, women with epilepsy, before they conceive, so that we can counsel them well. It starts with education regarding nutrition, all vitamins, irons, proper hydration, then counseling regarding possible complications, then teratogenicity of drugs. All this needs to be explained. Then the genetics of their epilepsy. It's a common question that they ask: will this disease be transmitted to the offspring? So counseling regarding the genetics of epilepsy and prenatal screening if required. And the seizure freedom. In an ideal scenario, a seizure freedom of at least 9 months will be good, because studies show that if there is a seizure freedom of 9 months, it is very likely that the pregnancy will go event free. And what about the drugs? So if we get the patient before conceiving, we can really plan how to go about the anti-epileptic drugs. Dr. Fiju did mention that if the patient is seizure free for about 2 or 3 years, a careful consideration can be done for a planned withdrawal. So if the patient is seizure free for maybe more than a year or 2, then consideration can be given for withdrawing the drug, so that the patient can have a drug-free pregnancy. Or if the patient is on multiple drugs, polytherapy, you can at least bring it down to at least one drug, which is ideal. Studies clearly shows that polytherapy is more harmful than monotherapy. So monotherapy is always preferred. So that will take some time. You need to chop off your drugs. So it's not stopped abruptly. It is stopped over days to weeks. So ideally 4 to 6 weeks time it will take. And of course, it also gives us a chance to change to less teratogenic drugs. So if the lady is already on valproate or phenytoin, we can slowly taper it down and maybe substitute it with a newer drug like levetiracetam. And the antidote for all the toxicities of anti-epileptic drugs is folic acid. So it should be co-prescribed. Actually, folic acid should be co-prescribed with anti-epileptic drugs to all women of reproductive age group. Then regarding the genetic disposition, actually the risk of children developing epilepsy is very, very low. It's very, very low. And certain syndromes, the IGE syndrome, the idiopathic generalized epilepsy syndrome, which is an EEG diagnosis, the risk of a child developing the condition, it depends if there is a one first degree relative affected, the risk can be 5 to 20%. If there are 2 first degree relatives, it can be 25%. And overall risk is about 9 to 12%. So this needs to be, this is only for the IGE syndrome and not for all epilepsies in general. So generally, we tell them that the risk of transmission to the progeny is very low. Now, what about pregnancy-related complications? We can have a lot of complications, but do they happen just because the lady has epilepsy? The answer is largely no. Epilepsy per se does not cause any increase in risk for preeclampsia or PIH or APH or PPH or premature labor. So even there is no increased requirement for cesarean. Cesarean is reserved for obstetric indications only. So largely there is no increased risk for pregnancy-related complications. What about vice versa? What happens to the seizure frequency in pregnancy? Does pregnancy change the seizure frequency? Not really. Most of the time it is unchanged. 54 to 80%, the seizure frequency remains the same. Sometimes it can be decreased or increased. An increase is more likely in partial epilepsy than in idiopathic epilepsy. And status epilepticus, which is life-threatening, there is no increased risk. And as said before, if patient is seizure free for more than 9 months prior to pregnancy, about more than 90% of them will continue to be seizure free during pregnancy. That's why I said that a seizure freedom of at least 9 months is most welcome before conceiving. Now, what happens if there is a seizure in pregnancy? If it is a non-convulsive seizure, it doesn't cause much damage to the mother or fetus. But if it is convulsive, if there are tonic-clonic movements, there can be fetal bradycardia or a miscarriage. If it is a status, then the situation is most alarming because it carries a high mortality rate for both the mother and the fetus. Now, what about the drug levels? So patient is on antiepileptics and the patient is pregnant. So can the drug levels be affected? Yes, answer is yes, it can be affected because the pharmacokinetics vary in pregnancy. It could be because of reduced gastric motility. It could be because of nausea and vomiting that can happen in the first trimester. It could be because of an increased volume of distribution, changes in protein binding, and increased renal blood flow, which can cause an increased elimination of the drug. Then altered hepatic enzyme activity, all these can alter the pharmacokinetics. And also another factor is the fear of teratogenicity, and with the result that the mother may skip the drugs due to fear of teratogenicity. All this can affect the drug levels. So AED levels in pregnancy, lamotrigine, there can be an increased clearance of the drug and reduced levels, which can result in a breakthrough seizure. The same applies to carbamazepine also, but usually we do not do the levels. We have facilities for checking phenytoin, carbamazepine, and valproate, but largely we do not do lamotrigine monitoring in our setup. Vitamin K supplementation, there is no increased risk of hemorrhagic disease in women with epilepsy. So it's like any other pregnancy. All newborns should receive 1 mg of vitamin K following birth, irrespective of the drug exposure. What about labor? The delivery should be conducted in a well-equipped unit. Cesarean section, as said before, is only for obstetric indications. The regular AEDs has to be continued. And if steroids are to be used for fetal lung maturation, a higher dose may be required, especially in those taking enzyme-inducing drugs. And overbreathing has to be avoided. Overbreathing or hyperventilation is a seizure trigger. In fact, hyperventilation is a technique that is used during EEG recording to unmask the epileptic form abnormalities. So hyperventilation can trigger a seizure. So that needs to be avoided during the period of labor. So also the sleep deprivation, extremes of pain and emotional stress, all this can precipitate seizures. So that has to be avoided. So a careful consideration for an early epidural anesthesia may not be a bad idea. All said and done, 1 to 2% of women with epilepsy will have a tonic-clonic seizure during labor. Another 1 to 2% will have a seizure in the ensuing 24 hours. So close monitoring is required, and advice for an SOS emergency medication needs to be always charted. Coming to the issue of teratogenicity, the drugs and teratogenicity is one of the factors that the mother is worried about, the family is worried about, the treating physician, the treating neurologist is worried about. One needs to know that you can have significant fetal malformations in women without epilepsy also, 1 to 2%. Women without epilepsy can have 1 to 2% incidence of significant fetal malformations. If on AEDs, epileptic lady on AEDs, this can go up to 2%, not on AEDs. Not on AEDs, it can go up to 2 to 3%. On a single AED, monotherapy, it is 4 to 6%, and more than one AED, polytherapy, it is 6 to 17%. So we can really see that the more the drugs, the more the chance of a fetal malformation. That's why I said before that the plan should be to cut short to as less as possible. Monotherapy is always ideal. And all the drugs that are written, phenobarbital, primidone, phenytoin, all of them cross the placenta in potentially clinically important amounts. So the risk of teratogenicity, trimester exposure, valproate is the villain most of the time. Most registries show valproate to have the maximum percentages of fetal malformations, major fetal malformations. So recommendation is to avoid valproate as monotherapy or polytherapy. And as said before, polytherapy always has an increased risk compared to monotherapy. The various pregnancy registries across the world, many of them are there. I have just quoted two. One is the UK registry and the URAP registry, which also is an international one. And you can easily see that valproate tops the list. 6.2 in the UK registry and 10.3 in the URAP study. And the other drugs like phenobarb 6%, phenytoin 6%, carbamazepine 5%, all of them are the bad guys in the group. Whereas you can see that lamotrigine and levetiracetam, they seem to be the safer ones as it stands today. So this will be the risk profiles of the anti-epileptic drugs that are available nowadays. So the best option will be to give lamotrigine or levetiracetam, and the worst will be valproate. And we know that the various teratogenic associations, the neural tube defects, cleft palate, cardiac anomalies, any of these anomalies can happen with any of the drugs. And the major congenital malformation type is not specific to any AD. And the dose also matters. The valproate doses, many times we see patients who are taking 200 mg BD or TDS and they go about their pregnancy unscathed. The studies have clearly shown that the teratogenicity of valproate goes up with doses above 600. So if it's a high dose of valproate, it needs to be brought down. And the most effects occur in the first 3 months. The neural tube closes between 3 and 4 weeks. Cleft lip occurrence before 5 weeks. The cleft palate occurrence before exposure before 10 weeks. And the heart diseases with exposures before 6 weeks. These are pictures of the fetal Hayden-Doyen syndrome, which is described with exposure to drugs like phenytoin, carbamazepine, trimidone, or valproate, with the various anomalies that are described. With advances in the drug therapy, we don't see them quite often now. Levetiracetam seems to be the drug of choice nowadays. It has low teratogenesis, as shown in the registries. Then good seizure control with the seizure rate which is comparable to the older generation drugs. Now, another factor which is gaining more importance is the cognition of the offspring. So even if the baby comes out without any anomalies, the IQ of the babies can be affected with certain drugs. Here again, valproate is the culprit. So it has been shown that the babies who have been exposed to valproate in utero, they have cognitive dysfunction. The IQ testing at 3 years, 4.5 years, and 6 years have consistently shown that many of them exposed to valproate have the suboptimal IQ levels. So even if there is no anomaly, the cognitive issue also puts valproate in the bad list. Then after delivery comes the puerperium. So if the dose has been escalated in pregnancy, puerperium is the time to bring down the dose so as to reduce the toxicity. Puerperium also means that the mother is waking up at odd hours to feed the child. So sleep deprivation can be an issue, and sleep deprivation is always a seizure trigger. So issues like sleep deprivation, stress, irregular food, medication timings, all this needs to be looked into. Breastfeeding, it's a strict yes. All women with epilepsy should be encouraged to breastfeed. The anti-epileptic drugs that are secreted in breast milk the amounts are very negligible and do not usually cause much problems to the fetus. So all of them should be encouraged to breastfeed. Of course, the drug can accumulate, like lamotrigine, benzodiazepine can cause infant drowsiness, phenobarbital can cause infant drowsiness. But the fact of the matter is we do not use these drugs nowadays in the treatment of epilepsy in pregnancy. Then menopause, as said before, women with epilepsy have altered hormonal cycles, so they end up with an early menopause. And what happens at menopause? There can be worsening of seizures in 40% of the women. There can be improvement in 27%, especially those with a catamenial pattern, and no change in 33%. If the woman is opting for HRT, the hormone replacement therapy, again, there can be an increase in seizure frequency, probably more likely in patients who have a catamenial pattern. And bone health, again, the enzyme-inducing drugs like phenytoin, carbamazepine, they can have AED-induced osteoporosis, and the risk of fractures in this group is always high. So all these patients should be offered regular bone density monitoring and calcium vitamin D supplements. So to summarize, epilepsy and AEDs affect various aspects of the reproductive health, ranging from sexuality, fertility, pregnancy, lactation, teratogenicity, and menopause. Most of the effects are minor, and with correct management, overall outcome is near normal. Overall benefits of seizure control with AEDs far outweighs the adverse effects of seizures on the quality of life and pregnancy outcome. So the drugs to be avoided are valproate, phenytoin, and phenobarbital. It's a strict no. The newer drugs like levetiracetam, lamotrigine, maybe even carbamazepine are relatively safer. And most of the newer AEDs, there is no much robust data on them, but levetiracetam seems to be the best. Always you should have a watch for PCOD. And always remember that it's monotherapy, which is ideal. The overall risk of teratogenicity on monotherapy is low. And there is absolutely no contraindication for breastfeeding. So I will sign off with this message. Majority of women, more than 90% with epilepsy, have normal children. So things are quite rosy nowadays for women with epilepsy. Thank you. Thank you very much.
Thank you, Dr. Unni. The floor is now open for any of the participants who would like to have any clarifications or comments.
Screen sharing on
I
Dr. Narayanan.
Yes,
Screen
yes.
sharing on.
see anything in the chat box.
Okay,
Yes.
thank you. Chat box. ഇല്ല ഒന്നുമില്ല. ചാറ്റ് ബോക്സിലൊന്നും കാണാനില്ല. ആർക്കെങ്കിലും എന്തെങ്കിലും ക്വസ്റ്റ്യൻസ് ചോദിക്കാനുണ്ടെങ്കിൽ ചോദിക്കാട്ടോ. Anybody wants to ask questions?
Or even to make any comments or raise any issues, you're very welcome.
വീഡിയോ ഒന്ന് ഓൺ ചെയ്യേ. ഡോക്ടർ സന്തോഷ് എന്തെങ്കിലും ചോദിക്കാനുണ്ടോ?
Hello. One question I have, which is the best antidepressant of choice for a patient on anti-epileptic drugs?
Dr. Fiji would like to take the question.
Fine. So, antidepressants are basically stimulants. Some of the antidepressants like fluoxetine can worsen or increase the irritability or seizure theoretically, but practically we don't find that much. In a low dose or a routine or starting dose, it doesn't. Some antipsychotics like clozapine, they are the most dangerous. If there is a seizure on that, we have to reduce it or add sodium valproate or something. But antidepressants, fluoxetine, escitalopram are potentially seizurogenic, but practically we don't find that much. If someone has flurry of seizures, we may reduce the dose or change our sertraline is okay.
I think really at the doses which we use, generally, there's not much of an issue. It's only when the psychiatrist comes into the field and uses these huge doses of fluoxetine or that we have an issue. Recently, I heard a very nice concept regarding what they called locus of control. Now, this is something which is a belief system. Now, people with epilepsy who believe that I am in control of my epilepsy. Now in these people, they have an internal locus of control, as opposed to some people who feel that the doctor is in charge of my epilepsy, my mother must take care of me, my father has got to give me the medication, God must take care of me, luck is not on my side. These people have an external locus of control. It's been found that those with an external locus of control have a greater degree of depression. It's also been found that most cases with epilepsy, where the problem is with this locus of control, they do very well with counseling. And if they are made to move from this external locus into an internal locus, where they are put in charge of their own disease, they do very well. And if this is the only problem, it can be handled this way. You may not even need an antidepressant. This was new intimation for me.
One more point is sodium. Many of the antidepressants cause hyponatremia, which in turn can cause a seizure. Fluoxetine, escitalopram are notorious in causing hyponatremia, which can cause seizure. So also oxcarbazepine, which is an antiepileptic, which can cause severe hyponatremia, which can cause seizure. That's a confounding additional factor.
In women with epilepsy, I think a very important take-home message is the use of folic acid in all patients, even 3 months prior to conception. Even when they are planning a pregnancy, it's important to start them on folic acid. Because by the time you know that they are pregnant, the neural tube problem has occurred. Because remember that neural tube closure occurs at about 3 to 4 weeks when she not yet missed her first period. So therefore, we need to start this much earlier.
It's safer to write folic acid 5 milligrams in the prescription of a lady 18 years. Whenever she plans marriage, let her start this also. I just write like a blank check. Just write folic acid 5 milligrams. I don't write 100, take it. That is, I have communicated with them. Whenever you marry, you take this also. Don't wait for pregnancy. Anybody 18 years. Just write this and instruct the girl and the mother that once you are married, take this.
If there are no further questions, can we hand the floor back to the president?
No more questions? Okay. Before going to then, ഈ മാസത്തെ മറ്റു പ്രോഗ്രാമിലേക്ക് I will go just give a run through. Tomorrow we will be having Children's Day interactive session. Children's Day was on November 14th and our state conference was going on that day. So we postponed to tomorrow. We will have a session on 7:30 by our WDWA, Women Doctors Wing IMA Thrissur. We'll have that 7:30 p.m. WDW chairperson, state chairperson, Dr. Kavita Ravi will inaugurate the function. That is tomorrow's program. After that, on 21st, coming Saturday, we will have our general body meeting, which will be conducted by the Apollo Adilex Hospitals, Karguti. And the topic will be on heart attack and overview by Dr. Julian. And second talk will be COVID and heart by Dr. Mahesh, both cardiology consultants of Apollo Adilex Hospital. And on 24th, we will have the World COPD Day with the Association of Ophthalmologists of Thrissur, 7:45 p.m. And on 29th, we will have Pink Mission on Sunday, 7 p.m. by the Pink Mission group under Dr. Shobana Mohandas. These are the programs coming in this month. So now I expect all are to join the coming programs without fail. We want more participants. Then that only gives an encouragement to the organizers to conduct more programs. Hope you all will join us tomorrow, 24th, tomorrow, 21st, 24th, and 29th of this month. And Dr. Fujin, you want to tell something? Okay. Okay. And before closing, I invite Dr. Sharmila for the vote of thanks. Over to you, Dr.
Sir, am I audible?
1 minute. She is the convener of CGP IMA Thrissur. Over to you, Dr.
Sir, am I audible?
Audible.
Yes, ma'am.
Okay, thank you. At the outset, I would like to thank Dr. Joy Manila and Dr. Pavan, our President and Secretary, for making the Thrissur branch of CGP the second best in the state. and also with today's meeting. And now I would like to thank Dr. Joy MA, who being the president of the Thrissur Neurological Society had a busy schedule today, but still he found time to give a welcome address. And thank you, Dr. Gilwas sir, for your introduction to this special day and the correction that it is our National Epilepsy Day and not the World Epilepsy Day actually. We owe a lot to Dr. Fiju Chako for taking us through the various types of epilepsy and approach to it. So a key or spoon should be definitely kept out of sight lest a commoner tries to manage epilepsy on his own. And now at this stage of this mobile camera, a video of the seizure episode can certainly be asked for. And it has been a pleasure to listen to Dr. Narayanan Unni as he spoke on women with epilepsy and the importance of taking medications as it affects 2 lives. Thank you, Dr. Unni, for that wonderful speech. And thank you, Dr. Santosh Babu, for making this meeting an interactive session. And also, I would like to thank the other members of the IMA who attended this meeting despite having a busy night or busy evening. And also, I would like to add that even as we wade through these troubled waters of Corona under the excellent captaincy of Dr. Joy Manila, we assure you that we will be coming with more such meetings in the future. Please do attend. Thank you. Thank you and good night.
Thank you. Thank you, Dr. Fiju, Dr. Narayan Unni.